Thank you very much for the kind introduction. First of all, I would like to thank the organizers for inviting me. It's a huge honor to be here. So I am going to talk today about reducing AKI incidence by implementing the KDIGO bundles. Acute kidney injury is a common complication in hospitalized patients, especially in patients in the ICU. Here, the incidence of acute kidney injury is about 50%. The most frequent cause of acute kidney injury, as you can see here on the left side, is sepsis, whereas the second most frequent cause is major surgery. This study investigated the incidence of acute kidney injury in different surgical specialties, and they demonstrated that acute kidney injury is a common complication, and especially after cardiac surgery. The authors demonstrated that approximately 20% of all patients undergoing cardiac surgery develop an acute kidney injury. This is another large retrospective study investigating more than 30,000 patients, and the authors investigated the epidemiology of cardiac surgery-associated AKI, and they demonstrated that approximately 1/3 of all patients undergoing cardiac surgery develop an acute kidney injury. Most of the patients develop a mild AKI, but 5 to 8% develop a moderate or severe AKI. Now you can argue, okay, a mild AKI is not so bad, but on the right side, the authors also investigated the mortality, and they demonstrated that a mild AKI after cardiac surgery is associated with a significantly increased mortality. As you can see here, the mortality is approximately 2.8%. In contrast to this, patients without an AKI have a mortality of approximately 0.6%. And the mortality further increases in patients with a severe acute kidney injury up to 40%. Furthermore, the authors calculated the odds ratio for the mortality, and this was 5.3 per one stage increase. In the last couple of years, several studies have been performed investigating different measures to prevent or treat acute kidney injury, however, without any success. So there is currently no specific therapy available. In 2012, the KDIGO guidelines were published, and the guidelines recommend to implement bundle of supportive measures in patients at high risk. And this is different from the sepsis bundle, because the sepsis bundle should be implemented in patients with an already established sepsis. But this bundle should implement it at patients at high risk. And this bundle consists of discontinuing all nephrotoxic agents when possible, ensure volume status and perfusion pressure, consider functional hemodynamic monitoring, monitor serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radiocontrast procedures. So acute kidney injury is a continuum that starts with an increased susceptibility and ends with an organ failure. An increased risk based on different comorbidities and a certain clinical condition and a kidney damage are clinically silent. If we have a disease progression, then the GFR goes down, and at the end, we have an acute kidney injury. Biomarkers are important to identify the golden hour of acute kidney injury. They can be used to identify patients at an increased risk and a kidney damage. And this is highlighted in this study, which shows that the kidney damage without a loss of function impacts patients' outcome. This study was performed by Michael Haas, and they divided more than 2,000 patients in 4 groups based on the serum creatinine levels and a biomarker. And in this case, they used NGAL. First of all, they divided the patient into patients with an elevated serum creatinine and patients with a normal serum creatinine. And I want to focus on these 2 groups. And in the next steps, they divided these patients into patients with a normal biomarker and an elevated biomarker. So patients with a normal biomarker and a normal serum creatinine had a low dialysis and mortality rate. However, patients with a normal serum creatinine but an elevated biomarker reflecting a kidney damage without a loss of function had a significantly higher mortality and dialysis rate. So this is highlighted in this viewpoint. The authors wrote, there's an additional value of new biomarkers, not only because they allow a diagnosis to be made earlier, but also because they allow a kidney injury to be diagnosed even in the absence of subsequent dysfunction. Furthermore, the authors wrote, the term subclinical AKI has been introduced, challenging the traditional view that a kidney problem is clinically relevant only when a loss of filtration function becomes apparent. Nowadays, we know a lot of biomarkers, and the best evaluated biomarker is probably NGAL. NGAL has been investigated in different patient populations. It has been shown that this biomarker has a high sensitivity and specificity. IL-18 was investigated, especially in cardiac surgery patients, and this biomarker has a good area under the curve, and we know a lot of other biomarkers. However, we can only measure 3 biomarkers at the bedside, and this is NGAL and TIM2 and IGF-BP7, and I will focus on TIM2 and IGF-BP7 in the next couple of minutes. So I will skip the next 2 slides because the biomarkers have already been introduced, and Dr. Kashani already presented the results of the Sapphire trial. Here the authors demonstrated that TIM2 and IGF-BP7 can predict a moderate and severe AKI within the next 40 hours after ICU admission. We also used these biomarkers in order to investigate whether they can predict an acute kidney injury after cardiac surgery in high-risk patients. And we identified these high-risk patients by using the Cleveland Clinical Foundation score. This score consists of different comorbidities, and for each comorbidity you get a certain amount of points. And the number of points you get correlates with a dialysis-dependent acute kidney injury after cardiac surgery. And we measured the biomarkers before surgery, 4 hours, 12 hours, and 24 hours after cardiac surgery. And here we looked for the predictive value of the composite value. That means we took the highest TIM2 and IGF-BP7 value within the first 24 hours, and the area under the curve for TIM2 and IGF-BP7 was very good. It was 0.896. But if you want to measure the biomarkers only once, you should do this after 4 hours. Here, the predictive value was still quite good. The area under the curve for TIM2 and IGF-BP7 was 0.805, and this was significantly better compared to the area under the curve of NGAL, which was 0.679. So biomarkers can predict an acute kidney injury. However, if we measure biomarkers in all our patients, the specificity goes down. And in 2010, Ming Shala and Stuart Goldstein came up with a renal angina concept. And this concept says that we should measure biomarkers in patients with a certain risk profile. And this risk profile consists of different risk factors. As you can see here, for example, chronic kidney disease, chronic heart failure, and a certain clinical condition, for example, sepsis or major surgery. And if the biomarkers are elevated in these high-risk patients, we can start a therapy, for example, start renal replacement therapy. And we used exactly this concept for our PREVACI trial. And PREVACI stands for Prevention of Cardiac Surgery-Associated AKI by implementing the KDIGO guidelines in high-risk patients, which were identified by biomarkers. This was a randomized controlled trial. This was a single-center trial which we performed in Münster. We started the recruitment in September 2014 and finished the recruitment in January 2016. Here you see the inclusion criteria: age between 18 and 90 years, written informed consent, all patients undergoing cardiac surgery, use of cardiopulmonary bypass, and we only wanted to include patients at high risk, and we identified them by measuring TIM2 and IGFBP7, and only patients with a biomarker level equal to or higher than 0.3 4 hours after cardiopulmonary bypass were included. Here are the exclusion criteria. Patients with pre-existing CKD not requiring renal replacement therapy. This was defined as a GFR below 30 mils per minute. We excluded these patients because we know that these patients have a different outcome. In this trial, we wanted to prevent acute kidney injury. That's the reason why we excluded all patients with a pre-existing AKI, patients with a glomerulonephritis, interstitial nephritis, or vasculitis, pregnancy, and patients after kidney transplantation. And here you see the study flow. So we measured TIM2 and IGFBP7 in all patients undergoing cardiac surgery, and we only wanted to include high-risk patients, so we included only patients with a TIM2 and IGFBP7 concentration equal to or higher than 0.3. These patients were randomized into a control group. These patients received the standard of care. We only kept the mean arterial pressure above 65 millimeter mercury and the central venous pressure between 8 and 10 millimeter of mercury, and the intervention group. And here we implemented the KDIGO bundle in high-risk patients, so we discontinued all nephrotoxic agents when possible. We also stopped ACE inhibitors and ARBs for 2 days because there is some literature suggesting that the use of ACE inhibitors in the perioperative period is associated with an increased risk to develop an acute kidney injury. We optimized the hemodynamic situation. I will show you the algorithm on the next slide. Monitor serum creatinine and urine output. Avoid hyperglycemia. Consider alternatives to radiocontrast procedures. And here you see the hemodynamic algorithm we used in our institution. So first of all, we looked for the volume status, and for this we used the stroke volume variation. If this was too high, above 12, we gave volume. In the next step, we looked for the cardiac output. If this was too low, we gave inotropes, and in the last step, we looked for the mean arterial pressure. If this was below 65 millimeter of mercury, we gave vasopressors. So if we achieved the goal, we checked this algorithm every 3 hours up to 12 hours. If not, we started from scratch. The primary hypothesis was biomarker-guided implementation of the KDIGO guidelines reduces the occurrence of acute kidney injury after cardiac surgery. The primary outcome was the occurrence of acute kidney injury within the first 72 hours after cardiac surgery. We used the KDIGO criteria to diagnose and stage AKI. Secondary outcomes were severe AKI within the first 72 hours, defined as KDIGO stage 2 and 3, mortality after 30, 60, and 90 days, renal recovery, length of ICU and hospital stay, and the composite endpoint, major adverse kidney events at day 30 and 90. This is a composite endpoint consisting of death, persistent renal dysfunction, and dialysis dependent. And here you see the flow chart. So we screened 882 patients. After cardiac surgery, 606 patients had to be excluded because 495 patients were not at risk for acute kidney injury. They had TIM2 and IGFBP7 levels below 0.3, and 106 patients met the exclusion criteria. So 276 patients were randomized, 138 into the control group, and the same number in the intervention group. First of all, we looked for the performance of the biomarkers. So 21% of all the patients with a low biomarker level, that means a TIM2 and IGFBP7 below 0.3, developed an acute kidney injury. In contrast to this, 72% of all patients with an elevated biomarker developed an acute kidney injury. So you can use these biomarkers to enrich the patient population and to identify patients at high risk. So we also calculated the negative predictive value. This was 79, and the positive predictive value was 72. Here you see the baseline and operative characteristics. This is a busy slide, but there were no differences between both groups. And here you see the measures during the intervention period. And here you can see that more patients in the intervention group received dobutamine compared to the patients in the control group, 31% versus 9.1%, and this was significant. And the incidence of hyperglycemia was significantly lower in the intervention group compared to the control group, and less patients in the intervention group received ACE inhibitors and ARBs. So the primary outcome was the occurrence of acute kidney injury within the first 72 hours after cardiac surgery. And by implementing the KDIGO guidelines or KDIGO bundle in high-risk patients, we were able to demonstrate that this procedure significantly reduced the occurrence of AKI after cardiac surgery, so from 72% to 55%. And if we only look for moderate and severe AKI, this could also be significantly reduced from 45% to 29%. So that I can say in conclusion, subclinical AKI worsens outcomes. This has been demonstrated by several studies. Biomarkers can identify patients at high risk for AKI and kidney damage. Treatment should be started early. We shouldn't wait until the kidney function declines. Our data suggests that biomarker-guided implementation of supportive measures reduces the occurrence of AKI after cardiac surgery. And I wrote here, suggest, because this was, of course, a single-center trial. And we are planning to repeat this trial as a multi-center trial, and this trial is supported by the European Society of Intensive Care Medicine, and we are still looking for centers, and if you want to participate, please contact me.